A twist in the MCQ was that he described a neonate with hematochezia. Now that again looks very surprising because you see intussusception will usually occur after the age of 6 months, where when you start introducing complementary feeding, you start introducing cereals in the child. It is very rare to have intussusception at maybe in a newborn age group. So neonate with hematochezia, the scenario given was that this was a home delivery, and unfortunately the mother had postpartum hemorrhage and the mother expired because of this. It was a home delivery. A ASHA worker was assisting, and this grand multipara, she had a gush of bleeding, and the BP became unrecordable. She became cold limp. They put her in a three-wheeler auto, brought to your hospital. As you know, half the time these 1091 and all these numbers don't work, ambulances don't reach, so they brought her in a three-wheeler auto to your hospital, almost lifeless, and you had to declare that she is died. She died at home due to PPH. Now, since the mother has expired, it is the grandmother who's taking care of this little newborn baby. And what this grandmother did was she gave cow's milk to the baby. You see, cow's milk is for a cow's baby, not for a human baby. If you give cow's milk to a human baby, cow's milk will be containing proteins like lactoglobulin, which are very difficult to digest. When you are giving cow's milk to a baby, that is when this child, this newborn baby, started having fresh blood in the stool. This presentation that I have written before you is that of NEC, that is necrotizing enterocolitis. So do take care of the age group for presentation as well, because when I'm talking about an infant, it was either a intussusception or it could be a rectal polyp. Rectal polyp per se will be causing no symptoms at all. It would just bleed. So the data on basis of prevalence is first rectal polyp, then Meckel's, and intussusception is anyway to be kept in mind when he talks about especially an infant 6 to 9 months of age with the word red currant jelly stool written. For necrotizing enterocolitis, I also want you to read more in detail from pediatrics regarding Bell staging. And one very characteristic manifestation that comes here is, and I'm just drawing it the way it will become easier for you to comprehend. You see, there can be erosion of the mucosa and the submucosa. You have air present in the lumen of the gut. Air is in the lumen of the gut, but now air is going into the submucosa. I mean, look at the surprising thing I'm telling you. Air is present in the lumen of the gut, but I'm not talking about air going into the submucosa area because there's an erosion present. This description that I've just given you right now is asked very frequently in pediatrics and is called as pneumatosis intestinalis. As you can see from the name, pneumostasis intestinalis highlights that there is going to be air present in the wall of the intestine. Mark my words, they're not in the lumen. Lumen, already air is there. It is in the wall of the intestine that is talking about. So, necrotizing enterocolitis from the pediatric perspective and unit perspective is also to be kept in mind. I dedicated these slides to the revision part and a bit of additional information. Coming to the subsequent part of our discussion, I'll now be explaining to you esophageal disorders. I'm now showing the esophageal musculature from the posterior aspect. I have shown muscle fibers in blue, which are arranged obliquely versus the circular arrangement of the fibers in green. So let me give them names here. The muscle fibers which have been shown in color blue is the inferior constrictor muscle. You can contrast the arrangement of the muscle fibers with the ones that are shown in color green, which is cricopharyngeus. You can also notice that at the junction of the two, there is a defect present, and it is from this defect that a outpouching can develop, which is called as Zinker diverticulum. You will notice that right at the bottom, the one in purple that I've shown is the smooth muscle, And again, there is a defect present here from where there can be a Zenker diverticulum developing. In the exam, the examiner would love to ask you regarding this particular area that I'm marking out in dotted red now. This is an area where muscle fibers are not there. There's only fascia present, so Zenker's diverticulum can develop. So they will ask you the name of this triangle which I've highlighted. Most guys are able to answer this correctly as Killian triangle, but I find that the same brilliant chaps sometimes are not able to answer for the triangle that I'm putting a sky blue star mark at the moment. This triangle, which is marked inferiorly, is what is called as Lymer's triangle. So get my statement right. Killian's triangle and Lymer's triangle are anatomical weaknesses from where Zenker's diverticulum can develop. As you can see in this image also, Zenker's diverticulum is posteriorly situated, and the area where it is gonna be located will be at the junction of the circular fibers of cricopharyngeus and the oblique fibers of the inferior constrictor muscle. Now, what are the problems that will be anticipated? There would be definitely some food that will impact in this area, and this food will keep on rotting, and that is why the person would come to you with symptoms of halitosis, that would be bad breath. Most of the time, the MCQs on this particular topic will talk about a old person. A geriatric age group presentation is usually seen with Zenker's diverticulum. Because we are talking about an old man, so you always need to keep a watch whether this could be a carcinoma esophagus as well, because even in carcinoma esophagus, because there would be a fungating growth, it will narrow down the lumen of the esophagus, so food impaction, food retention can occur, and because of that, when the food will keep on rotting, again the halitosis component can come in. Please remember the fact that when you read a question that begins by saying halitosis, regurgitation of yesterday's food items, do not be under impression that this is a standard feature only with Zenker diverticulum. Even a cancer having a fungating growth and causing a substantial luminal obstruction can cause similar kind of symptoms. The disease that I'm explaining to you here is Zenker's diverticulum. The highlight of this condition will be that it would be a geriatric age group patient. I want you to understand that even cancer can occur in relatively old age groups. So mixing up the two disorders, that is cancer of the esophagus and Zenker diverticulum, is a possibility. I want to highlight the fact that in cancer, the fungating growth of the esophagus can be substantial enough to cause obstructive symptoms. So regurgitation of yesterday's food items can also be written in a question related to malignancy. And that basically means that how in a question would you differentiate on clinical grounds whether he's talking about Zenker or whether he's talking about esophageal cancer? Well, I want you to remember that in Zenker's diverticulum, the symptoms are not gonna dramatically increase, unlike a cancer which will keep on increasing in size. So in 6 months, 8 months, 9 months, the cancer is becoming bigger. So there is a progressive dysphagia. Whereas when it comes to Zenker diverticulum, the size is almost gonna remain the same. So this will always talk about non-progressive dysphagia. Do remember my statements which I have highlighted here. Progressive dysphagia with cachexia is a feature with cancer, but when you talk about non-progressive dysphagia along with the symptoms written on the top, it is Zenker's which is to be kept in mind. The most common site where Zenker diverticulum is located has already been discussed, that is Killian's triangle. You read about that even in ENT, even in surgery, so I think that's you are comfortable with that. The investigational choice for this condition is a barium swallow. For management of this condition, it is surgical resection of this diverticulum which is to be done. Most of the time, errors can occur with respect to this topic only if you don't read the question carefully, because as I've highlighted, if it is progressive dysphagia, you need to give first differential diagnosis as cancer of the esophagus. Because I spoke about dysphagia at this particular scenario, I also want to put up a question here which said that dysphagia will occur when how much percentage of luminal obstruction of the esophagus will occur. Like let us assume this is the esophagus and then there is a fungating mass of esophageal cancer and now it's becoming bigger and bigger and bigger and bigger and bigger and is causing substantial luminal obstruction. So at how much of percentage of obstruction will the person tell you that I feel as if the food is sticking behind my chest bone? So remember at least 66%. If there is more than 2/3 of luminal obstruction occurring, that is the time when dysphagia symptom will develop. This was number or a value based question, like he gave options like 30%, 50% like that, but this has some logical interpretation in a sense that dysphagia will usually develop in esophageal disorders very late. Imagine the cancer is so big that it is causing 66% obstruction. That is when the person will say that I feel something like food sticking behind my chest bone, or I feel as if the food is not going down. So you need to have a high index of suspicion in any patient having difficulty in swallowing. You must, especially in geriatric age group, keep in mind a possibility for malignancy, as you will see in the subsequent discussions and the subsequent subtopics that I discuss with you. Whenever esophagus will have peristalsis, the peristaltic wave will move in a forward fashion so that when one part of the esophagus is contracting, the subsequent part will be relaxing. Once the food will reach the lower 1/3 of the esophagus, then we have the lower esophageal sphincter, which is having a resting tone. In fact, the question to you guys at the moment, because this is an overlap from surgery, is what is the resting tone of the sphincter? You see, with how much pressure should the lower part of the esophagus contract so that the food passes into the stomach? Then the tone of the sphincter is a range. It is 15 to 25 millimeters of mercury, and once it contracts, the lower part of the esophagus contracts with substantial force more than this one, that is when it will open and the food will go into the stomach. We have a peristaltic wave going up, and therefore the food can easily pass into the lower part of the esophagus. But now I'm showing a condition where whole of the esophagus is contracted in a single go. Please appreciate that unlike the previous diagram, this time I'm showing that the upper part and the middle part and the lower part, whole of the esophagus is contracting simultaneously. Well, the condition that I'm introducing now after Zenker diverticulum is called as diffuse esophageal spasm. In this condition, the main symptom of the patient will not be dysphagia. Why? Because you see, blood vessels, the one that I'm showing in red are the blood vessels of the esophagus. The blood vessels of the esophagus traverse through the muscles only. In this condition, because whole of the esophagus will contract with force, the force will constrict the esophageal blood vessels, and now I have shown these blood vessels constricted, which explains why this condition will be called as esophageal angina, and therefore the symptoms that are encountered in a patient of diffuse esophageal spasm, the first one is not dysphagia, it is chest pain, which will make you think that he's having a cardiac issue, and you will refer this guy to a cardiologist for ECG or maybe a treadmill test or workup of chronic stable angina or blockages in the coronary artery will be done. But in the end, the report will come out to be normal because the problem is not in the coronary circulation. The problem is in the esophagus of this chap. So we need to have a high index of suspicion for this condition. Why? Because if you are having chest pain persisting in a guy and the cardiology department has said no cardiologic issue, ECG is normal, stress echo is normal, coronary angiography is normal in this guy, and still there is development of chest pain, then you need to think in terms of this being a non-cardiac cause of chest pain. The usual complaints of these patients is chest pain at rest. How would you differentiate this chest pain at rest from that of MIE? In myocardial infarction, the chest pain will be occurring on a continuous basis with sweating, pulmonary edema manifestations. Here, the chest pain will be occurring on an intermittent basis. Please remember the fact that most of the time when you rule out the cardiac causes in these patients, that is when these patients realize their second symptoms. Because initially, if somebody is having chest pain, I'll put it on myself. If I have chest pain, first thought process of mine is something is wrong with the blood vessels of my heart. I'll go and see a cardiologist. But once you tell this guy nothing wrong with the coronary circulation, that is when he will realize the subsequent symptom, because chest pain per se is such a predominant symptom that a person will not be able to appreciate the dysphagia component. It is intermittent chest pain which is present in this condition, though that's very subjective, but there will be no evidence of any diaphoresis, breathlessness, pink frothy sputum, or pulmonary edema findings that I've discussed in the cardiac part. As such, because this is not a cardiac condition, so evidence of pulmonary edema or sympathomimetic stimulation will not be present. Well, why does diffuse esophageal spasm occur? It is idiopathic. It is an idiopathic condition which is contributing these manifestations. Now, how do you evaluate that this is diffuse esophageal spasm? I said this is a diagnosis of exclusion. Always rule out coronary artery disease by doing, if possible, a treadmill test. If you can't walk like an obese person, you can do a stress echo, and a baseline ECG will obviously be done on the first presentation with maybe cardiac biomarkers to rule out the coronary etiology. If he says what is the investigational choice for this condition, your answer will be given as esophageal manometry. You see, lots of times surgeons love to talk about barium swallow. I will talk about barium swallow findings in this person as well, but I want you to appreciate that the best evidence of diffuse esophageal spasm is to record the pressures in the esophagus. Here, they would ask you that the pressure of the esophagus will be more than how much to call it diffuse esophageal spasm. So, if the pressure recorded is more than 120 millimeter of mercury, you see the systolic blood pressure is 120. If esophagus will contract with a force more than 120, that is when it will constrict its own blood supply, and that is why we call this condition also as esophageal angina. In fact, lots of time in the exam, the way they will give the question, you will be tempted to answer it as chronic stable angina, coronary artery disease. But please appreciate the fact that in chronic stable angina also the symptoms of chest pain come on exercise. Here is having symptoms at rest. And as such, the cardiac profile is normal. If you record on manometry, the pressure is more than 120 millimeters of mercury for more than 3 seconds, we will call it diffuse esophageal spasm. Then there is a variant of this. The variant of this is called as nutcracker esophagus, where the pressures recorded will be even much higher. If the pressures, the intraluminal pressures are turning out to be more than 180 millimeters of mercury for more than 6.5 seconds or a little more than that, that is when you will use the term nutcracker esophagus. Well, you see, our examiners have this habit of asking values also. So here I would definitely like you to get these pressures right. Do remember two numbers, 120 and 180, and durations are 3 seconds and more than 6.5 seconds. When it comes to diffuse esophageal spasm, they can also give you a barium swallow finding, which is very characteristic and easy to identify. I have never seen anybody missing up this particular finding unless and until somebody is reckless or casual. As you can see, very particular manifestation of nutcracker esophagus can be seen. The radiologist will love to hear use the following terms. Either he will use the word corkscrew esophagus, or he might say the word rosary bead appearance. Both of these are surrogate terminologies which basically highlight that, well, there is a problem with the contraction part and whole of the esophagus is contracting in a single go. Couple of guys have casually answered this as esophageal candidiasis. You see, in esophageal candidiasis, the appearance will be slightly different. So let me just show you another image in which the appearance of the esophagus of the patient is slightly different. If you compare this with the contralateral image that I've just highlighted on the screen at the moment, you will notice that there is a very irregular margins. You see, there's no rosary bead. It's very irregular margins. So I would just like to call or use the term shaggy appearance of the esophagus. This shaggy appearance is what is seen with esophageal candidiasis. In fact, in the question, he can also give you risk factors for esophageal candida. Obviously, AIDS is one of them. I have explained that in the AIDS section, that oral candidiasis is not gonna be making you suspect AIDS, but if a person is having invasive candidiasis, that is esophageal or bronchus or lungs getting involved, that is where you will think in terms of possibility of AIDS. And apart from AIDS, another important risk factor can be an asthmatic taking inhaled corticosteroids. I repeat the statement once again. Asthmatics, if they're taking ICS and they're not doing a rinsing of the mouth, because you see, when you take a puffer, lots of time the drug might be deposited in the pharynx only, and that is where there's a possibility that the infection can go down also and can involve the esophagus. So if he gives you a scenario of a immunocompromised person like AIDS, that would be easy, or a person who's an asthmatic and is on inhaled corticosteroids, then this irregular appearance or shaggy margins are what is in favor of esophageal candida, whereas you can notice very clear indentations which will help you identify the corkscrew appearance. So I personally feel that there is no reason why the two conditions can ever be missed. Now we will come to the treatment part of diffuse esophageal spasm. Here I want you to remember that rather the drugs which have shown improvement in the general condition of this patient is not nitrates or calcium channel blockers. In Harrison, he has mentioned that in trials, it is anxiolytics that have an important role. Why? I can explain like this. If I'm having chest pain, my first thought process would be I'm having a heart problem. Even if you reassure me, no, your angiography is normal, your ECG is normal, I might doubt you. I might doubt your diagnostic acumen. I might say, oh, this doctor is not very qualified. He's telling me I'm having chest pain. He's saying no cardiac problem. You see, patient will have his own thought process also. So anxiety is something which can contribute to worsening of this condition. So anxiolytics have had the best role in management of this condition, and because you know that anxiolytis can be habit forming, like if you're giving clonazepam 0.25, the person will develop a habit of using it and then subsequently will also be having sedation. So a non-sedating, non-habit forming anxiolytic that you are aware is bispiron, which can be used in this condition. If he says what drug will relieve the chest pain, then the controversies between nitrates and calcium channel blockers, I want you to appreciate that nitrates are first to be answered, because per se for chest pain, the first drug always used is nitrates. The nitrate that I'm going to use in this case, however, is not a short-acting one. I'm not going to use nitroglycerin. I'll have to use it again and again, plus side effect, a headache, and other side effects can also come like edema. It is long-acting nitrates that would be recommended, that is isosorbide mononitrate for these patients. Along with this, calcium channel blockers are to be answered. I basically wanted to highlight the fact that most guys begin by discussing calcium channel blockers or nitrates as the primary treatment of this condition. But actually, if you look at the efficacy of the drugs, everything that I'm going to tell you is in decreasing order of importance. It is anxiolytics, then is going to be nitrates, then is going to be calcium channel blocker. You can use a long-acting one like amlodipine, which will